Going to get started. Welcome everyone to the final session of our Global Leaders in Implementation Science seminar series of 2025. I'm Guillaume Fontaine. I'm an assistant professor at McGill, and I will be your moderator for today. So today I'm very pleased to welcome one of my close colleagues, but also a leader in implementation science, Dr. Justin Presseau, who's a senior scientist and director of the Methodological and Implementation Research Program at the Ottawa Hospital Research Institute, also an associate professor in the School of Epidemiology and Public Health and the School of Psychology at the University of Ottawa. He was trained as a health psychologist, completed a PhD in psychology at the University of Aberdeen, moved back to Canada in 2015, and then since then has built a prolific program of work on theory-based behavior change interventions, the role of habit, automaticity, and the design and evaluation of implementation strategies across a wide range of networks. He's really doing it all. And he's a fantastic scientist, but also a fantastic person. So please join me in welcoming Dr. Justin Presseau. And Justin, the stage is yours.
Fabulous. Thank you, Guillaume, for those kind words and for the opportunity to present in this series. Let's share my screen. Okay, and thank you to everyone online that has taken some time out of your day to listen in, or indeed if you're listening in at another time asynchronously. So I'm really excited to have the opportunity to talk about an area of our work that has really been a thread across a lot of different projects over the years. And this is the idea of how do we understand and support and change more than one behavior at a time. So I'm going to go through a range of different studies from the perspective of both behavioral and implementation science, mostly because that's the interface at which I work, working with health behaviors as well as trying to support healthcare professionals and health systems in providing the best care that they can. But before I get started, I just wanted to flag where I'm coming from. So I'm based in Ottawa, where I have the privilege to work alongside some incredible implementation scientists. We have 11 implementation science faculty and their interdisciplinary teams that are really focused on taking a range of different perspectives to advancing the science of implementation. And I wanted to flag that in case you ever find yourself in Ottawa for a short period of time, or indeed if you wanted to have a longer stay with us, never hesitate to reach out. We'd be glad to connect. And then just some disclosures. This is the funders that I'm grateful for funding our work, and I don't have any other disclosures to provide. Okay, so let's get started. I want to make the case to you, first of all, that from my perspective, from my vantage point, one of the fundamental units of analysis and targets for change in implementation science is behavior. Hopefully that's not too controversial to say, but depending where you're coming at this from, that might not be the typical lens that you might approach this as. But what I'd like to put to you is that whether it's a new clinical practice guideline, a care pathway, a technique, a medication, an intervention, a policy, a technology that we want to put into practice, or indeed that we might want to support de-implementation or de-escalation, fundamentally somebody in the health system needs to change what they do, usually more than one person, more than one behavior, which we'll get into. But fundamentally, this is about, in my mind, behavior as a key unit of analysis. And to hammer that point home a little bit more, if we think about exemplars from the literature that highlight gaps between evidence and routine care, the kinds of things that ultimately certainly get me up in the morning to do the work that I do. This is a paper that undoubtedly many of you have seen before, that by my colleague Janet Squires, that highlighted the extent of inappropriate clinical practices in Canada, which is highlighting mainly a story of underuse of care that could be provided based on evidence and recommendations that isn't quite up to that standard yet. But if we dig down a little bit further, and we look at the types of underused and overused clinical practices within reviews such as Janet's, we see their lab tests and referrals and assessments and screening and blood test imaging, medication, that these are all, in my mind, these are behaviors. These are activities conducted within health systems by healthcare professionals and their teams. And unpacking these challenges in behavioral terms provides, in my mind, a useful lens. And our typical approach in implementation science might be to approach tackling these gaps in care using one of our process models, something like the classic knowledge to action framework, or the more theory-tied French model. But typically, or at least in many applications of these types of process models and these attempts to address gaps in care, we tend to focus on one specific practice to change for lots of good reasons. But even though that's how we end up focusing our attention in terms of implementation and behavioral research, people don't live one behavior lives, clearly, and people don't work in one behavior jobs. And so what I want to spend my time today is exploring what are the implications if we think about this more broadly from our methods perspectives and our theory perspectives in implementation science. What could we do to recognize that multi-behavior complexity of people's lives and people's work within the context of implementation science? So to contextualize that a bit more, I wanted to introduce you to two people. So first, meet Sarah. She's 32 years old. She works full-time downtown. She's married, she has 3 kids, and she manages a chronic condition, type 2 diabetes. She just so happens to be enrolled in a trial of a theory-based behavior change intervention designed to support people with type 2 diabetes to increase their physical activity. So as an interventionist and a trialist, we might be interested in supporting Sarah to engage in that particular behavior that is of interest to us in the team, and the guidelines that might support it. But of course, that is not the only thing that characterizes Sarah's life. She's trying to eat healthily in the morning, get her kids to school, wait in traffic, spend lots of time at work, maybe a bit more sedentary than we might like, or she might like, trying to eat healthy lunch, keeping the house clean, going to shop with her kids, taking some time out for herself, hanging out with her family and her friends where she can, trying to get a good night's sleep, keeping up with medication regimes. So clearly, this is a full life that is characterized by much more than the behavior we might be interested in this case, in promoting physical activity for Sarah. Some of those behaviors are other health behaviors, some of them are not. But the point being, there's a multitude of other aspects that are potentially more of a priority than the behavior we are interested in as interventionists. But also I want you to introduce you to Dr. Alukal. She's a family doctor. She works in a busy downtown practice with 3 other family docs, and she's Sarah's doctor. She sees Sarah every few months for her diabetes checkup and review. And her practice also happens to be enrolled in a trial of, in this case, an implementation intervention to improve referrals to eye screening for diabetic retinopathy screening for people with diabetes. A recognized referred to aspect of diabetes management. So if we think about the context of Sarah coming in to meet with Dr. Alukal, and we as implementation researchers might be trying to support Dr. Alukal's practice to refer more to diabetic retinopathy screening. But again, of course, there are other things, other guideline-recommended aspects of diabetes management that Dr. Alukal has to weigh and consider, and right? So the point being, the focus aspect that we are interested in as in an implementation research project, in an implementation effort, is embedded within a wide variety of other activities that compete for time and attention and resources in this particularly time-constrained situation. And so what that highlights is some of the limitations of focusing on one practice or one behavior at a time. Arguably, there's some questionable ecological validity because the settings in which we're aiming to try to support people to change, whether in everyday life or in clinical practice, they're clearly characterized by lots of different behaviors vying for limited motivation resources. And depending on where you're focused on in terms of models, theories, and frameworks, most of at least the applications of our traditional and go-to MTFs tend to be operationalized and even theorized with the idea of trying to focus on one behavior to understand, to develop interventions, and to evaluate change. So there's an insufficiency potentially of the predominant approaches that we're taking theory-wise, which leads to, I think, at least two different situations. One is a kind of glass half empty perspective, and another is a glass half full. So there's the potential of what I might call a whack-a-mole risk, that a given intervention, even if we're successful in supporting Dr. Lucal to refer more or to support Sarah to do more physical activity, it might be at the expense of other existing behaviors, depending on what other resources are available. But we don't actually know that because we don't typically look at those other behaviors when we're intervening and evaluating. But similarly, there might be missed opportunities for synergy of knock-on effects or tipping points that, again, a given intervention might successfully improve that target behavior that we're interested in. But that could be a good thing. It could set the stage for other behaviors to change as well. But again, we don't typically actually look at that. We focus down on the core behavior, primary outcome of interest. And from my perspective, and what I put to you today is evolving into taking a more behavior system paradigm might help us to address some of these limitations. So I wanted to walk you through some of the work that we've been engaged in to try to tackle that specifically. So three particular insights that I wanted to share across some of our work that I'll cover are: first, our behaviors are not independent of each other. Second, that we're not starting from scratch as it relates to theory. We have a strong theoretical foundation upon which we can build. And third, that we can develop and test interventions to change more than one behavior. And so as I go through these, I'll provide you some examples, both from the context of trying to support health behavior change in patients and in populations, as well as trying to support healthcare providers changing their clinical practice behaviors. So let's start by the first insight, that behaviors are not independent of each other. So this is some work that was led by one of my former PhD students, Zach Van Allen, and we asked ourselves, can people be organized by the extent to which they engage in many different health behaviors? Can we characterize people by how much they engage or not in a range of health behaviors? So we got access to the Canadian Longitudinal Study of Aging data, which involves just over 40,000 people in mid to older adulthood. And what we applied cluster analysis, hierarchical agglomerative cluster analysis, drawing out, in this case, we had access to 7 health behaviors that were being measured within this data set. So we're interested in, can we organize people by how much they're engaging in each of these behaviors? And so these radar plots, to situate you, highlight the different clusters of people that can be defined by the extent to which they engage in multiple different health behaviors in this data set. So the yellow lines are the standardized mean for everyone in the data set, and the red lines are the standardized mean for that particular cluster. So you can see the extent to which the red deviates from the whole population. And so if we look at, for example, cluster 1, these are people that are characterized relative to everybody else in the data set as physically active, healthy eaters. They're walking more, they're exercising more, they're doing more, eating more fruit and veg, doing some light sports, compared to, let's say, cluster 5, that we characterize as frequent walkers that don't do strenuous activity, but drink more alcohol than the average of the population. And so the implications potentially of categorizing or clustering people by the multiple behaviors that characterize their daily life is there might be implications here for tailoring to account for the extent of those to which people are engaging in more than one behaviors in ways that we don't typically tailor our interventions. But looking at, do we focus in and design interventions to support people that accounts for the rest of the behaviors that they're engaged in? But then we asked ourselves also, and we were inspired by the early work by Nick Christakis and others in the social network analysis space, that in that area would very much provide us insight on the interconnectedness of people's behaviors interindividually in this work involving tens of thousands of people, and looking at the nodes and how different behaviors that people are engaged in are connected to other people. And we asked ourselves, what if we applied that perspective to within individuals, so that rather than the nodes, those circles being people, that they're behaviors in people's own behavior network, so that each node is potentially linked to other nodes, and with some behaviors being more central in a person's behavior system, others more peripheral, and we can start to think of each person as having their own behavior system, their own behavior network. So Zach spent a lot of time developing the foundation analytical approaches to explore that question. So again, we used the CLSA data set, as well as a second data set that also included a number of health behaviors within the context of the pandemic, using relatively large data or sample sizes. In this case, he used graphical Gaussian modeling to model and visualize the network of, in this case there, you can interpret them as partial correlations between behaviors. So we're looking at how our behaviors connected within people, accounting for every other behavior. So if we look at the CLSA data, we can see that there are, when we account for all behaviors at the same time, we can see there are small relationships between behaviors after accounting for the relationship between other behaviors, which allows us to visualize to what extent different behaviors might or might not be interconnected within individuals. So a way of visualizing as well people's behavior system. And we did the same thing again for that second data set to see if we could replicate the analytical approaches, in this case in a public health crisis. And what's neat about this particular analysis is the pandemic protective behaviors seem to connect with one another, as you might expect, but are relatively independent of other types of health behaviors. So, and that even the health behaviors themselves, the health protective behaviors tend to be connected with each other and not so much with the health diminishing behaviors. So again, it's another way of capturing and visualizing the extent to which people are engaged in multiple behaviors and how those behaviors might connect with each other. So what are the implications here? I think for behavior clusters and behavior networks, it helps to demonstrate that we can actually map these out. We can look at the various behaviors that people are engaged in. And when it comes to clusters, as I said, there could be ways that we can approach tailoring our interventions by accounting for how much people are engaged in lots of behaviors. And by identifying networks of co-varying behaviors, like in those network analysis, we can start to look at those ideas of knock-on effects or spillover effects. If we change one behavior, what's the impact on the other behaviors within individuals? In my mind, there's so much opportunity to apply these foundational analytical approaches that Zach developed in other data sets that assess multiple behaviors, especially when we think about applying this to healthcare and routinely collected data. There's so much potential for that going forward. Because it allows us to, and it also, from my perspective, opens new research questions that we are not yet able to ask ourselves with our traditional ways of framing our questions. Because by pivoting to these system-based approaches, we can start to ask ourselves what happens to the other behaviors in the network when one behavior is changed, either increased or decreased or added or stopped, so that we can really capture the impact on everything else and look at that whack-a-mole potential effect. But also which behaviors are most central are the things that we are, as interventionists, interested in the central behaviors in a given person's network or not, which is a look at the relative priority and how many degrees of separation between that central versus the peripheral behaviors that people are engaged in. And can we focus on a central behavior to promote spillover effects on our target behaviors? So lots of, I think, interesting implications for leveraging some of these early analytical applications of network analyses to behaviors. So that's focusing on the sort of behavior level, but ultimately, so in order for us to continue to accumulate an evidence base and to get on the same page about the mechanisms through which these might happen, we need a strong theoretical foundation, both to build from and to build on. The good thing is that there is some early and some strong theory from which we can draw from to understand the dynamics of how different behaviors might affect each other. So I wanted to walk you through a couple of examples of work that we've been involved in to try to explore some of those theoretical aspects. So the first question in this space, we asked ourselves, what if we tested a theory across more than one behavior in the same sample? It's not developing theory, but it's leveraging the fact that we could be testing the same theory across multiple behaviors in the same group of people. So this work is based within the context of trying to support primary care physicians and nurses to engage in clinical guideline concordant diabetes care, and started off with a large study across the UK, 99 different UK primary care practices. And here we were interested in understanding, using available data, what are the gaps in care in specific guideline recommended practices in diabetes care around prescribing, advice, and foot examination, and highlighted there's room for improvement in particular areas of diabetes care across at that time point in the UK. And then we took the opportunity to then ask ourselves, could we test a theory to try to explain variation in clinician behavior that accounts for their motivation, their post-motivation, post-intentional processes, and their habits at the same time, which is that small model in the top left. And so we ran a relatively large prospective correlational study where we sent out postal questionnaires at baseline and a year later to GPs and nurses across the UK, where the main outcome was a self-reported clinician behavior at that time point. And so we had 6 different guideline recommended behaviors upon which we were testing this particular theory. And so let me walk you through the findings themselves, but then draw some broader conclusions about the approach itself, which is the main point I want to make here, is that what we were able to do by comparing multiple tests of the same theory in the same population of clinicians is that we found support for this reflective process, the intention through post-intentional processes, either directly or indirectly across all the behaviors. And alongside, for 4 out of the 6 behaviors, we found a role for that more automatic aspect of clinical practice, working alongside the more active decision-making processes. But the bigger point I want to make is that, from a multiple behavior perspective in clinical practice, we could test the same theory across multiple behaviors, at least as a way to internally replicate our theory test, if that's your jam. Or it also provides an opportunity to look for, are we seeing the same relationships across different behaviors in the same group, which might suggest an opportunity to tailor how we approach a multiple behavior change intervention for clinicians. So that makes the case for testing existing theory across multiple behaviors. But what about advancing theory itself? How do we continue to learn and to grow our understanding of how behaviors connect and why they might influence each other? We have another level of foundation in the theory space that we can draw from. And one of the most important, in my mind, contributions in this space is the work of Ari Kuklansky and Eilert Fischbach and others around what they call goal systems theory. And this is really a theory that helps us to understand the structural aspects of how behaviors connect with each other, where behaviors are linked to each other and to a series of higher level goals. And the two of the main concepts that I find really useful in goal systems theory is this idea of multifinality and equifinality. So multifinality is this idea of one behavior, if you engage in it, can serve to achieve multiple goals. And in their work in other areas, they've shown that that's particularly useful, efficient, and linked to starting a new behavior. So if you engage in a behavior that serves lots of goals relative to a behavior that only serves one goal, it's really good at getting going. So an example of this in clinical practice might be staff nurses vaccinating their coworkers in peer vaccination programs, which, if you work in a hospital, might be something that you are seeing right now. That clinical behavior potentially achieves multiple goals here: improves vaccination rates, protects self and colleagues and patients, builds confidence in vaccines from a trusted source, and potentially reduces absenteeism. Equifinality is the other end of it, that multiple different behaviors can be used to achieve a goal. And in this case, it's associated in their work with resilience and especially sustained implementation. When you have options to reach a goal rather than only one doing one thing, you're more likely to be successful. So an example here, supporting blood pressure management can be achieved by multiple different means. In this case, an example of equifinality. So that's a kind of structural representation of goal systems and multiple behaviors, how they're connected. There's also some moves in trying to understand the mechanisms of why some behaviors and not others might be affecting each other. And a few different lenses to this, I think, provide some clues to us, and one of which is extensions to control theory. And so for those of you listening in, the control theory is one of the foundational elements of the audit and feedback implementation strategy. One way of approaching it, this idea that you have a benchmark, a goal that you're trying to reach, and that by comparing that to what you're actually doing and looking for any discrepancies, there's a feedback mechanism, a feedback loop to try to reduce the discrepancies between goals and action. It's a kind of in a nutshell control theory. And there's been a lot of work to draw from that, usually one behavior focus of control theory, and extend it to how to combine multiple behaviors so that depending on different factors, which different behaviors might be focused on within the context of that feedback loop. And from my perspective, given the maturity of the field of audit and feedback, hundreds of trials in the recent Cochrane review led by Noah Ivers in this space, and the recognition that there's a need to move beyond business as usual, this would be, I think, one way to approach going beyond business as usual and audit and feedback is to move into that multiple behavior space and the theory that might support it. Then there's some other theoretical literature that's mostly from the health psych space that proposes that, for example, if you're looking at understanding eye screening referral, you could ask clinicians about their self-efficacy to refer their eye screening, but that self-efficacy could not only be related to their eye screening referral behavior, but some other aspects, and so that it's looking at the cross behavior cognition aspect. And then there's finally another mechanism of interest is how compatible behaviors are within a system. And this idea of harmony or facilitation between behaviors versus conflict that one behavior might undermine another behavior. And it's this in particular that I'm going to spend just a couple of minutes talking to you about some of the work that we've been engaged in that particular type of mechanism. So I'll look at this from the perspective of a health behavior and then a health professional behavior to try to make that point. So we asked ourselves, how do multiple behavior constructs help to predict a health behavior? And so in this case, we were interested in understanding objectively assessed physical activity over the course of a week. And so we asked ourselves, there's these standard theories, theory, plan, behavior that say, intention and perceived control are the two big predictors of any health behavior. Let's at least control for that. And then does considering the impact of other behaviors help us to understand a health behavior over and above the kind of standard predictors from a standard theory? So we controlled for those. And then we looked at two ways of assessing how the rest of people's behaviors might impact on their physical activity. One was a cognitive assessment. So we asked people to report on how much they perceived other behaviors in their daily life to either help, facilitate, or interfere, conflict with their physical activity, and use those scores to predict their physical activity. Then we took it one step further and asked ourselves, what about, perception is one thing. What if we actually look at the amount of time people spend in facilitating and conflicting behaviors? Is there a resource element here that if you spend more time in other behaviors that help you to do physical activity or more time in conflicting behaviors, do you do more or less physical activity? And so when we ran our analyses, we found that when we look at the perceptions of, even after we control for that kind of standard intention, perceived control for that given behavior, that perceptions of how other behaviors are helping your physical activity predict objective physical activity, but not conflict. But when we look at how much time people actually spend in those behaviors, in other behaviors, that's where conflict comes through, that other behaviors that interfere with physical activity, if you spend more time in that, you do less physical activity. So maybe that's not rocket science to show and to suggest, but It moves us beyond the let's just focus on applying a standard theory with one behavior, and it actually recognizes that there's an impact of other behaviors, both positive and potentially negative. And that means we could consider that wider behavior system when we're trying to, in this case, promote physical activity. Apply to healthcare providers. So we did an exploratory study as well with physicians not on the doing of physical activity, but in this case of providing advice to engage in physical activity to their patients. And so again, we were trying to recognize that that's not the only thing that a physician has to do or might want to do in a consultation with their patient. And so we did the same thing, control for standard constructs, and then added perceptions of how other activities in the context of a clinical encounter help or don't help providing physical activity advice, and found that these both contributed to understanding the extent of physical activity advice over and above that kind of standard intention, self-efficacy, perceived control. So again, in clinical settings, in more constrained, resource-constrained settings, this was also relevant. And it's a reflection, these two examples are reflections of what we're seeing across multiple different studies, that at the very least, when we ask participants, whether they're healthcare providers or patients or members of the public, people readily identify, maybe unsurprisingly, other behaviors that are important to them besides the one that we're interested in, and can report on how much those other behaviors interfere or help the behavior we're interested in. And not always, but more often than not, those when we measure those, they help to account, at least in the designs that we've used so far, for the extent to which people engage in those behaviors over and above the standard predictors from classic theories. So I think there's a real opportunity to dig in even more across other types of settings and behaviors and populations. So that's the theory side. We talked about the behaviors and the structure of the behaviors. We talked about theory. The last insight that I wanted to share is intervention focused. So can we develop and test theory-informed interventions to change more than one behavior? So I wanted to talk through some pieces of work that were led by another one of my PhD students, Carolina Silva, who did one review, first looking at the health behavior side, where she was interested in what do we know about interventions that are trying to change more than one behavior. So she reviewed the literature focused on people with chronic conditions for interventions that were trialed to change, interventions that change more than one health behavior that were trialed in health contexts, and found 61 different studies. And what's interesting when you focus on the literature, that this multiple behavior change literature, there are other types of aspects that you can extract from these studies. One is how many behaviors are they trying to change at once. And in this review, that on average they tried to change 3 different health behaviors in their interventions, but there was a range from 2 to 5. Maybe unsurprisingly, mostly this is a physical activity and eating literature, that the most targeted 2 behaviors at the same time. But there's a range of clusters. Sometimes smoking is involved too. And she did some careful unpacking of behavior change techniques reported in each of these interventions, and also looked at order effects. Are these interventions they're mostly interventions that are trying to do it all at once, change all the behaviors at the same time in the same intervention, but there's a few that are changing one behavior and then another in that sequential approach. And then she did some meta-analyses that the way to interpret these is each of these behaviors are embedded in a multiple behavior change intervention. And so does trying to change fruit and veg, physical activity, sedentary, smoking, alcohol, medication within the context of a multiple behavior change intervention lead to the change in that given behavior? We can see that by and large, yes, is the answer across most health behaviors, whether measured continuously or in a dichotomous way or where possible in an objective way, that there seems to be a small to medium, roughly speaking, effect expected when you change more than one behavior on a given health behavior. So if we tease that out, what does that look like in a given trial of more than one behavior, trying to change more than one behavior? So this is a a trial that was led by Noah Ivers from Women's College that I had the good fortune of being involved with, where we were trying to support people post heart attack to take particular medication and to attend cardiac rehabilitation, and did some careful co-developed work to try to develop an intervention, and then trialed it in a multi-site RCT in Ontario in 9 cardiac centers. And we did our careful homework to map and used a particular theory, the health action process approach, and mapped behavior change techniques to those to try to change intention for the 2 behaviors, medication adherence, cardiac rehab, as well as post-intentional strategies to try to get that good intention over the line for medication adherence and cardiac rehab attendance. And what we found, and I should have mentioned earlier that there were 2 intervention arms, one that was the intervention components were delivered by mailouts, and the second that was mailouts plus supportive calls to patients. And when we look at cardiac rehab attendance, we found in particular that mailouts plus calls had significantly greater attendance to cardiac rehabilitation, but no effect at all, clearly, of the intervention on medication adherence. And then we had the good fortune of having Nicola McCleary on the team to help us really unpack the mechanisms of how can we understand why did this work for one intervention or one behavior and not another. And so she ran some theory-based process evaluation questionnaires for each of the 2 targeted behaviors, in this case with patients. And was able to model out for, in this case, cardiac rehabilitation. We could specifically demonstrate how the mail out plus calls arm was successfully influencing both intention and cardiac rehabilitation attendance through the specific factors that we were targeting with our behavior change techniques. And also did the same for medication adherence, that she was able to show that the intervention, the mail out and calls were successful in changing some of the constructs, but that wasn't sufficient to lead into medication adherence. So also provides some clues to what else might we do to try to get that over the line. We were able to change the mediating factors, but not the primary outcome in that case. But the bigger picture point that I wanted to make is, this is a trial of a multiple behavior change intervention, in this case 2 behaviors, using similar behavior change techniques and methods of delivery, 2 important behaviors at the same time. The process evaluation helped us to unpack mechanisms. But if we ask ourselves, what if we only chose to focus on one of those 2 behaviors? We would have had a vastly different interpretation of the intervention. But in our case, we only showed change in one of the 2 behaviors. Does that mean it's not an effective intervention, or it is an effective intervention? Thankfully, we published our protocol and had some interest holders involved, and they told us a priori that the intervention and the trial would be deemed a success if we can change at least one. But it opens up the bigger question of how do we interpret multiple behavior change intervention and trials of those types of interventions. So that's for patients. What does that mean when we look at this from a health professional perspective? We're trying to change more than one health professional behavior. So Carolina also did a similar review with healthcare professionals, identified 17 trials of interventions that were designed to try to change 2 or more clinical behaviors. In this case, one of them, because of her interest in her PhD, one of those behaviors had to be a health behavior change advice behavior. But even with that constraint, there were 17 trials that were trying to change that behavior plus a range of other clinical behaviors. And then she did some really careful unpacking using behavior change intervention ontology, the different ontologies, to really characterize the content of these clinician-focused multiple behavior change interventions. So of these 17 trials, mostly they've been targeting physicians, MDs, but also nurses and physiotherapists and some combination. Very few of them are using theory at the moment. Mostly these are delivered, at least in part, by healthcare professionals to other healthcare professionals, delivered in various modes of delivery, and using at least one BCT was identified across every intervention group. But few of these studies actually tie their behavior change techniques to any theory, and indeed only one did. So what does that look like? Just as we looked at Noah's trial, what if we pulled out one of these interventions, and this so happens to be one of mine? that what if we asked ourselves on the back of that earlier work I talked about, what if we try to change 6 clinical behaviors at once? So we designed and ran a cluster randomized trial trying to improve 6 different guideline-recommended health professional behaviors in primary care management of diabetes, where we randomized 44 UK practices, had a 12-month follow-up using health records or patient report of clinical behaviors. And what do we find? The intervention didn't work. Prescribing and examination, when we looked at the health records, showed improvement, but improvement in both groups. And then the patient-reported outcomes showed actually slight increase in more education in the control group and no difference in nutrition or physical activity advice. So even though primary care is defined arguably by having to manage multiple clinical behaviors, there's a question, maybe there's a dilution effect. Maybe we're trying to do too much in one intervention, simultaneously trying to change 6 behaviors at once with the same group of behavior change techniques. But what if we look at this study? This is a study published in The Lancet that was focused on using feedback and education reminder messages, again, to primary care, again in the UK, that was specifically focused on lab tests, trying to reduce lab test ordering. So this is a neat 2x2 factorial trial, similar size, in this case, feedback and information for 9 different tests. And if we look at on the right, the primary outcome, which was a composite across those 9 different tests, it suggests strongly that both these intervention strategies are effective in changing or reducing lab test ordering in primary care. But if you look at the specific behaviors that make up that composite index, there's a much less consistent pattern. And if we think about what if they only focused on carbohydrate antigen 125, they would have concluded this intervention wasn't effective. Whereas if they picked vitamin B12, they would have. And so it highlights to me an interesting nuance in the fact that this is clearly masked by a composite index. And there's value in assessing these other behavioral outcomes, but it clearly has implications for our trial design and analytical methods. But there's potentially more efficient, but the implications of targeting more than one behaviors, at least it's more efficient. You're doing more than one at a time. But just as for the intervention that I led in primary care, mostly these are just do more type interventions rather than being a bit more nuanced. And I think that the next generation of these interventions might benefit from that slightly more nuance than just trying to add more behaviors. But at least for health behaviors, I think there's pretty good suggestion that targeting more than one seems to be a good idea, but it's an open question given the 2 examples and the review that Carolina led for health professionals. But my sense is there's probably way more out there. We're just scratching the surface in terms of these reviewing these trials, that given the way that we report our interventions and we pick a primary outcome, that there might be ways of interrogating the trial data, the trial literature, to really look at, are they actually trying to target more than one behavior? And there's ways that we can do that by either deep diving into large reviews like the recent audit and feedback review, but also prospectively to evaluate that nuance in interventions in the future to look at that behavior system. So what would that look like on the health behavior intervention side? Let's say we were interested in supporting older adults to walk more. We could ask ourselves, do we have the strategies to understand the fit of that behavior in their behavior system? Can we improve how well that health behavior is integrated alongside everything else? Can we check to see how resilient that behavior system is? Can the other behaviors shield any setbacks to walking? And are there tipping points? Could we target, if we try to get older adults to walk more, does it impact in a positive way their other activities? Or do those other activities actually, if we targeted those, would it set the stage for them walking more? They're all ways that we can approach intervention development that considers that behavior system. And similarly, with healthcare professionals, let's say we're trying to increase referral to eye screening, same questions. How does this fit alongside everything they do? How resilient is the system to shield any setbacks on referral? And clearly we can look at this not only intrapersonally, but across people, across clinicians in an interpersonal way in teams and health systems. So finally, I think there's a real opportunity for us to move to a behavior system paradigm because it opens new questions. It creates new opportunities for innovation in behavioral and implementation science. Methodologically, for example, we could start to map and measure the system of interdependent behaviors using some of our existing methods. We can leverage the data infrastructures that increasingly we have available to us at the provincial level and in EMRs in healthcare systems that are collecting lots of behavior data. But we need a robust theory to underpin this, so we're not just shooting in the dark, that we're actually learning from each other and growing and understanding mechanisms and building that cumulative evidence base. Maybe it provides a new way to think about equity, as well as thinking about what are the constraints on people's lives and the rest of what they're engaged in, how that affects how they're engaging in a particular behavior itself. There's opportunities to consolidate our strategies that are focused in a more behavior system approach. And there's opportunities to think creatively about how do we formalize analytical and design recommendations for trials that are targeting more than one behavior, looking at knock-on effects of other interventions. So for my money, there's just so much opportunity to lean into these questions from various different vantage points. And if you're interested in this space, please do reach out to me. But I wanted to finish off by just bringing us back to the start and remembering Sarah. She has a full life of other behaviors, and remembering Dr. Aluko has to update her clinical behaviors as new evidence changes amidst the many competing demands. People don't live one behavior lives, and they don't work in one behavior jobs. And so I challenge us to advance the science of implementation by leaning into this, by embracing the complexity of multiple behaviors. And as I say, if you're interested in exploring this with me, if you're not already, please do reach out. Thanks.
Thank you so much, Justin. That was an amazing overview of a small portion of your program of work, but it's fascinating. And I love that you brought in both the health behavior aspect, but also the healthcare professional aspect and different levels of application as well. So we have about 10 minutes for questions. So please use the Q&A function for any questions to ask to Dr. Presseau. I have multiple questions, but I'm going to start with so I really liked at first when you presented the work that was led by Zach Van Allen around within-person correlation between behaviors at one time, right? So I have kind of 2 points about that, I guess. One is about if this was explored over time, you know, within this set of data, and if not, what do you think would be the implications of looking at those correlations over time within an observational context or within an intervention context? And the other point that I was thinking is that I'd like to know your thoughts about, you know, those behaviors were health behaviors, so related to someone living in the community within a group of family, friends, you know, a family unit, let's say. So your thoughts on the expected correlations maybe with the behaviors within this group versus what we would observe for a nurse, for example, working on a healthcare professional on a hospital unit, you know, and the correlation of behaviors within the person, but also the other people in their group. So basically, would we expect to see differences between within person and between person correlations for patients versus nurses, for example? And your thoughts on that?
Yeah, amazing. So for your first question, I didn't present on this, but Zach also did, it just recently published a paper on what he called temporal network analysis. And so specifically looked at in a longitudinal data set, and accounting for things like autocorrelation and looking at the contemporaneous cross-sectional aspects and controlling for that and looking over and above that, what are the temporal potential associations and are those maintained over time? And it provides actually a better test really than a cross-sectional one, and starts to look at the potential bidirectionality of some of these, that if you do one versus another, that when it's cross-sectional, we can't really know which comes first, but we could start to at least explore that in those temporal. So all to say that he's explored this, and the R code has been developed to explore this further if you happen to have data sets that that might lend themselves to either that cross-sectional or that longitudinal approach. And then in the case of exploring this within the context of, let's say, nurses in a setting or healthcare providers in the health system, I'm speculating on this, but my sense is, at least based on some of the other work that we've been doing with health providers, that the nature of the setting provides much more constraints than everyday life. And so the potential knock-on effects of doing one thing or another within a time-limited space with other people, I would expect to have stronger relationships than in everyday life, where there's more time, potentially more resources. And so, but that's me speculating. And I think if or anyone on the call has access to measures across multiple behaviors in a clinical team, or multiple clinical teams, that this would be a gold mine to explore some of those questions. And then bringing in the interpersonal, I think it applies not only to the healthcare teams, but also even to the general population too, that there's this question of the intra versus inter, and we've focused mostly intra at the moment, but certainly the social impact of others and others' behaviors, especially if we think about process mapping, for example, that some behaviors are contingent on others, especially in healthcare settings, that, to be able to do one thing in your job depends on other people, and understanding those contingencies, I think, is part of that behavior system.
Yeah, thank you for that. No, that sounds, that's very interesting. Okay, I have another question. So the other question is related to, I guess, speaking more about the methodological implications of targeting multiple behaviors for the development of an implementation strategy. It's in a research context or not in a research context, but for implementation practice or implementation research. So from your experience and what you've seen from trials, for example, what are the key, I guess, implications?
Implications for how we approach the strategies?
Yeah, I guess developing strategies that would target, one behavior versus multiple behaviors. Because I mean, if you look at, all of the intervention development models, for example, the behavior change wheel, right? It's highly focused on behavioral specification, and okay, we have one behavior and then all flows from that, right? And then we have this whole process that follows. And I feel like, do we have to duplicate this process, 6 times if we have 6 behaviors, is basically my thinking. And I don't quite know, so what do you think?
If I jumped in my time machine and went back to when I ran my trial, that was the trial in the UK, in primary care, that was the approach that guided my thinking, that this is just about, scaling up to more behaviors, but same process. We're basically developing 6 interventions, same BCTs, same everything. But I'm not convinced now that that's the right approach, especially if there are different factors affecting those different behaviors. We should be tailoring basically to each of the behaviors, not same BCTs, same everything, and trying to change all at once. And so I think, and in looking at Carolina's review that included all those types of interventions, that's the state of the science right now, in the state of the field, at least in the research reports of these trials, is that sticking to the traditional intervention development approach and just increasing the number of behaviors. So it's kind of more work on the intervention development team, as well as more work to change in the system. But I think that's where I'm excited, is to move beyond that. What if we looked at this from a different perspective at the behavior system level? How might we approach together a more nuanced, not just try to change everything using the same factors, but being a bit more deliberate about it. But I think that's the cusp of where things are at, as far as I can tell, at least in this space.
Yeah. Another question I have is okay, I see 2 questions. Sorry, I'm going to ask some of so Laura Gian Gregorio is asking, to be able to use EMR data to look at health behaviors related to physical activity, strength training, balance, exercise, nutrition, we need valid data collection measures to get healthcare providers to ask about them. Our research suggests that these data are rarely collected, and if they are, the data are messy. What do you think?
Yeah, it's a fair point. It's a really fair point, and maybe I'm hand waving a bit to the potential of routinely collected data for this, but I think the the larger point I think that I would make is if we focus our energies to say we want to be exploring the multiple behaviors and we need better measures of those, then we need to think about what are the key multiple behaviors we want to be assessing and then working to improve the measurement side of things. But I mean, this applies to any intervention that involves behavior, whether it's one or multiple, that fundamentally we depend on the quality of the measurement itself, and exploring our different opportunities for collecting valid data. I think it's a big part of that, and maybe it's accentuated in the context of doing this across multiple behaviors. So, but it's a point well taken, Laura.
Thank you. Sami Mortaz is saying, thank you so much, Justin. Curious to hear your thoughts on ways of clustering the behaviors to the target. Would different clusters of behaviors among same people in the same context result in better outcomes?
Different clusters of behavior among the same people in the same context. I mean, that's the idea behind the work that we've done, that instead of having a one-size-fits-all intervention, or that we only look at one behavior and maybe focus on people that are doing less of that behavior, that if we look at a few different behaviors and the extent to which people are doing more or less of that, and they're coming from the same population engaging in these behaviors in the same context, that we might design different interventions for those clusters. But then I'm speculating from then on that we have nobody that I know has done that work to tailor to these clusters. But it strikes me that it pairs neatly with the multitude of behavior condition-specific guidelines that nobody can follow all those different guidelines at once. And this is a way of thinking about if we have to do more physical activity and eat healthily and take medication and reduce your alcohol intake, that those live in separate guidelines. But this is a way of thinking about them together and thinking about, because we're thinking about them together, could we design interventions that are specific to how much they're engaged in all of those behaviors? But yeah, nobody's gone to the next level, at least that I'm aware of. But if anybody on the call knows of that work, please do forward it to me, because that's to me, that's the exciting next bit, is to, what are the implications intervention-wise?
Thank you. And Laura quickly is saying, it is my experience that you need to design interventions for patients and providers in tandem and tailor them separately as the behaviors are happening in a system. Would love to chat about this. So yeah, someone to connect with, Dustin.
Great. Yeah.
Thank you so much, Dustin, for your time today, for your presentation. It's been amazing having you. The presentation is going to be recorded, so we're going to post it on YouTube, share it with everyone. And if you're comfortable also sharing your slides, Justin will send them to all people who were registered for the seminar.
That's great. No, thanks so much for everyone's time and for this opportunity. It's been great.
Thank you so much, Justin. And we'll be announcing the program for the 2026 series soon. So stay posted. Bye-bye, everyone.
Great. Thanks.